Hey doc, it's Nick. You had shared a patient you're looking for some insight on, tooth number 15, or patient's chief complaint was pain in the area of tooth 15 in the upper right. And you had astutely taken a CBCT as your two-dimensional radiographic methods and your clinical evaluations were inconclusive, which is not atypical. As we know, the CAT scan is not a tool that we use as a first-line defense, but more of an adjunct if and when our normal tools and technology doesn't give us what we need. So we still have to follow the ALARA and or the ALADA principle in minimizing radiation when we can. With that said, I definitely think this is a case that lends itself to this technology because it gives us a lot of information that two-dimensional PAN or APA would not give us. So in a nutshell, when I'm looking at a CAT scan, I'm going to go through everything, all of the information that's there, which I have done. I didn't see anything overly abnormal in the other areas of the mouth. With that said, when we take an image, we are responsible for the contents of that image. So developing the eye to be able to identify when something doesn't look right, and then sending it off to an oral radiologist, oral surgeon, or somebody else that's an expert in the arena where the entity might be located. But the topic of today's conversation is really non-odontogenic pain. So if we have a situation where the patient's complaining of a toothache, there's two things that come to mind, especially in the upper. The first is the sinus, which is most likely the culprit here, and the other is trigger points from a radiating pain pattern from a muscle that's in myofascial pain disorder, essentially a Charlie horse of sorts. So when a patient comes in, before I even take the CAT scan, I'm going to palpate some muscles. You and I have gone over this, so topic for another conversation. But before you take the CAT scan, you want to rule out muscles. So you've done your odontogenic clinical exam, you have your PA, you don't see anything. Before taking the CAT scan, go to the muscle exam. I've sent you the referral patterns for the masseter. The masseter has several trigger points which refer pain to the upper molars. If that's not it, then the CAT scan comes in. All right, so let's just assume that you did that. There was nothing conclusive in the muscle exam, nothing wrong with the joint. Sometimes the joint can refer pain in this area, but it's pretty obvious what's going on here now that we have the CAT scan. So when I'm looking at the maxillary sinus, we want to take a look at the Schneiderian membrane here to see if there's any thickening. And thickening in and of itself is not too uncommon. With that said, it typically means there's something going on. That's where our ENT colleagues come in very handy. Let me just start by saying we don't have bilateral thickening of the membrane, which might give us a clue this is not seasonal allergies or something more systemic in nature, but more localized. So we're starting to zero in on what the problem might be. Now, when I look at, and I'm still not 100% comfortable with navigating the software yet, so bear with me. The buttons are opposite of the technology I normally use. But I like to look at things from many different angles. Don't look at a tooth from one pane, one window pane, and come up with a conclusion. But instead, look at it from multiple angles. So the first angle I'm going to look at is the sagittal view here. Let's come out of that. Sagittal view. And what I'm going to do is I look for the color of the line that's not in this pane. That tells me that's the line that I'm looking at. So I don't see green here. So if I come over here and grab the green line, I'm going to see that upper right pane move. So again, the line that's not represented in the pane is the line that's representing the two-dimensional image from the other two-dimensional images. So you see two green lines here. You don't see the green line here. This is just basic CAT scan analysis. So going through the sagittal as I'm coming across, I'm looking for obvious decay. There might be something here. There might be something here. The resolution of this particular CAT scan is extremely high, and I don't know if I've come to an understanding on whether or not this is active decay or not, as this resolution is much greater than anything I've used in the past. So something we're going to have to learn over time. But for the sake of this argument, let's just assume this is not decay. If it is, it should show up on your bite wings. But the moral of the story here is we want to look at this sagittal view from many different angles. So I'm going to start from the buccal and come across. And I'm looking at that upper right pane to see if there's anything abnormal with the roots, with the tooth themselves. This might catch your eye right here. This is not an abnormal appearing area. This is more just, I don't want to call it mock band effect, but we can think of it as mock band effect. It's not uncommon when the root is sitting in this little triangle of cortical bone that the cancellous bone next to it looks more radiolucent than the surrounding radioopaque cortical bone. You have the floor of the maxillary sinus right here, and it's not uncommon for this to appear that way. What I'll typically do is I'm going to, when I see that, make a mental note and then look at it from the axial view. If it was something of pathologic nature, I would probably see something more convincing on the coronal view here. So let's just take this line here. I'm looking down here. I don't see the orange line, so I'm going to come over here to grab the orange line, and I'm going to go up. And I'm looking at this right here. So this is the distal aspect of the mesiobuccal root of number 14, which is this area right here. This is where my eye is, but I'm coming over here to scroll. And I see this radiolucent area here, but I see a lamina dura of the PDL. I still see trabeculation inside of this area here. So I'm going to chalk this up to an artifact or just a anatomical aberration and not something pathologic. So we can dismiss that. But walking through this stuff in your head is how you start to evaluate these images. So coming back to the sagittal view here, I'm going to continue panning this way towards the palate. Now I'm going to make a mental note. These roots are sitting right in the sinus, or right adjacent to the cortical bone and or the Schneiderian membrane of the sinus. Spoiler alert, I think that's what's going on here. Now the question is the chronic sinusitis of this area due to an odontogenic problem, or is the sinus inflamed from something related to the sinus that's causing pressure of the nerve fibers coming out of the tooth, thereby giving tooth pain as the patient's symptom? We'll dive into that in a second. So I don't really see anything in the way of vertical root fractures. You know, it's rather atypical to have a vertical root fracture on a tooth that's unrestored, or at least not heavily restored. Once we start seeing endodontically treated teeth, teeth with large amalgams that don't have coronal restoration, so on and so forth, those are higher risk teeth for vertical root fractures. So I'm already starting to think this is probably more related to the sinus than a vertical root fracture. With that said, we have to keep that as part of our differential at this point because we don't have evidence to suggest that we don't have a vertical root fracture. And again, we don't always see vertical root fractures on the CAT scan, even these high resolution CAT scans. So I don't see anything periapical on any of the roots in this area. So I really don't think this is a standard necrotic pulp situation with a periapical involvement. Endo treating the teeth would be helpful. It's uncommon to have vital teeth with a periapical issue like the patient's presenting. So if you endo treated these teeth and you had a positive response to cold and or EPT, that strengthens the argument that this is sinus in nature. If they're necrotic, it doesn't really give you a whole lot of evidence other than the diagnostic process becomes more gray, not less gray. So let's assume both of these are vital. Just based on what I'm seeing, I would assume that to be true. Again, this decay might be relevant if it is decay. I don't have the bite wings in front of me, but let's just kind of table that. So now I'm going to come back up here. So I've completed my sagittal analysis through panning this green line kind of back and forth. I may make a small notice right here. It looks like there might be a radiolucent line that could be suggestive of a crack. With that said, that's such an uncommon area for a crack, so I'm looking at this right here. If anything, that might just be a nutrient canal coming off of the pulp. So I'm looking at right here. With that said, I'll make note of that. I also see the same thing here. The odds of having both of those present in two different teeth, 1 in a million situation, which would more or less cause me to move on. So now I'm going to look at the lower left view here and pan up and down. This is a great view to answer the question, how many canals does the patient have? But really what I'm looking at is the periphery of the tooth to see if there's any fenestration of the buccal plate. Now, once we start to get in the bone here, I'm looking around the tooth. I don't see anything abnormal yet. This is very normal and very common. You're just going to have to develop the eye to know that that's just regular cancellous bone. Really, as I extend apically, I don't see anything abnormal around the root tips. And then the last view is this frontal view. I don't see anything on 15 other than the obvious sinus response to either something related to the sinus or the teeth themselves. When they're odontogenic in nature, so when the sinusitis happens as a result of a tooth problem, it tends to be more isolated and symmetrical around the tooth itself. Although this could be an advanced situation that has started to spread, this really speaks to me more of a chronic sinusitis or acute sinusitis issue that is of non-odontogenic origin. Which brings me to the literature. So there is, Jeff Okeson wrote one of the preeminent textbooks on TMD and oral facial pain, and he has a whole chapter on this. I have a copy of the book if you want, but he talks about when is pain that is surmised as a tooth problem actually not a tooth problem. Trigger points being another common example of that. So understanding this body of the literature would be helpful. And then also, this is a review of the current literature on odontogenic sinusitis, which is when the tooth is the problem and you see sinusitis, what can happen. So I'm happy to share these with you. Just let me know. What you did, I think, is spot on. You gave him Augmentin. Augmentin is the right choice when we have suspected sinusitis. If the patient is allergic to it, Z-Pak would probably be the next best one. Depends on which ENT you talk to, but that's my current line of reasoning. But Augmentin being the best, great part because of the beta-lactamase aspect of the bugs found in the sinus commonly. Really, we're talking about the anaerobes, and the anaerobes are the ones that cause these bigger problems. So Augmentin referral to the PCP. I'll be honest, whenever I send a patient to the PCP for something like this, I encourage the patient to demand for an ENT referral. PCPs are not, they're not trained to handle something of this complexity. You're more likely to get the patient to show back up in your chair because the PCP said you need to see your dentist, which is just a colossal waste of resources considering you're the one that referred it to the PCP in the first place. What I found is by sending this to the ENT, and I'll often send screenshots of the CAT scan, find the best view that indicates what you're seeing. This right here would be good. And then you say something with a high degree of confidence, something to the effect of, through our thorough dental testing, we do not see any reason for this to be, tooth-borne in origin or odontogenic in origin. So you really want them not to think this is tooth related, so that they start to think harder about what it could be related to the sinus. The more we practice, the more we know. Clinicians love punting patients to dentists whenever it's somewhat related to teeth. It's an easy, low-hanging fruit for medical practitioners to get rid of patients, making it our problem no different than we do the same for them. Where this becomes valuable is we're being very diligent about presenting the information that this is highly unlikely to be tooth-borne in nature. All right, so I hope this helps. Let me know if there's anything we can do. I would definitely like to have the conversation maybe about the occlusion and how that could play a role. With that said, I didn't see any widening of the PDL around any of the teeth, but occlusion can be an exacerbating component to this conversation. So I just wanted to mention that. But I think what you did was spot on. So congrats on that, and let me know if we can help any further. Take care.